what if the medical world has fundamentally misunderstood chronic pain for, well, the last 50 years?
I mean, that is a massive question to open with, but honestly, it's a valid one.
Have a think about it for a second. Millions of people suffering, billions of dollars spent, and an entire opioid epidemic just ravaging communities. And all of it perhaps stemming from a core misunderstanding of what pain actually is.
Right. A complete misapprehension of the underlying biology.
Exactly. So imagine, if you will, that your body is a house, and pain is a highly sophisticated state-of-the-art home security system.
I like this. Okay.
Acutely, when everything is functioning exactly as it was designed to, it is a brilliant, highly specific alarm. Say, a window breaks in the living room.
Yeah.
Immediately, a loud, piercing siren sounds right in that specific room.
Spot on. You instantly know where the danger is.
Right. You know what has happened, and you know what you need to do to stop it. You board up the window, the threat is neutralized, and the siren shuts off. It makes perfect linear sense.
It does. And that linear sense is the evolutionary triumph of acute pain. It's an immediate, life-saving directive. I mean, without it, the house burns down because you never notice the smoldering rug.
But then we have to consider what happens when pain becomes chronic, when it, stops being a temporary warning and becomes this persistent, unyielding state.
Yeah, that's where the system breaks down.
Right. It's as if that brilliant home security system has completely malfunctioned. And worse than just malfunctioning, it is as though the wiring has somehow become crossed and fused directly into the house's central thermostat and the lighting grid.
Oh, wow. That's a visceral way to put it.
So now, when the siren rings, it doesn't just make a noise. It fundamentally alters the environment. It dims all the lights in the house. It drops the temperature by 10 degrees.
It the entire atmosphere.
Exactly. It changes the very atmosphere of the home you are living in. The sensory input, the alarm itself, has somehow transformed into an emotional and motivational environment that you just cannot simply switch off.
That is a phenomenal way to conceptualize it. And it brings us directly to the core of what we are unpacking today. Because for a very long time, both in medicine and in the broader culture, we've treated pain merely as a symptom of somatic disease.
Just a physical symptom.
Right. We've operated under this Cartesian dualism, this idea of a simple physical event, a broken window that simply needs to be numbed or patched. But that view is fundamentally incomplete, and frankly, it's why we've failed so many patients.
Which is incredibly tragic.
It is. So today we're dismantling the misconception of pain as a purely physical, linear event and reconstructing it as a deeply integrated brain-mind phenomenon.
And that reconstruction is the entire mission of this deep dive. For you listening, we are explicitly framing psychiatry today not just as the study of mental illness, but as the study of how brain, mind, and experience interact, and crucially, how that intricate process can go wrong.
Absolutely.
We're using Kaplan and Sadok's comprehensive textbook of psychiatry to explore how nociceptive signals, the raw physical data coming from your body, are literally transformed into the subjective, lived emotional experience of pain.
This is arguably one of the most vital shifts in modern clinical understanding. For anyone practicing medicine, especially psychiatry, you have to realize that the sensory aspect of pain, the intensity, the location, the quality of the ache or the burn, is only one dimension.
Only one piece of the puzzle.
Precisely. Pain possesses massive affective and cognitive dimensions. It's an experience entirely constructed by the brain. When that process becomes maladaptive, when the pain becomes chronic, it induces profound neurobiological changes. We're no longer just dealing with tissue damage in a knee or a lower back.
We're dealing with a transformed central nervous system.
Exactly.
Okay, let's unpack this. Let's start right at the foundation of that transformation. Because if we are going to understand this, we need to draw a really hard, explicit line between two concepts that I think most people, myself included, to be honest, usually use completely interchangeably. Nociception and pain.
Yes, they are definitely not the same thing.
If I'm tracking with our house metaphor, nociception is the mechanical hardware detecting the broken glass, but pain is the software's interpretation of that event.
That is a crucial distinction. Nociception is just the physical transmission of a signal. It's initiated by the activation of peripheral nociceptors.
The end organs.
Right. These specialized sensory end organs located all over your body. They're in the skin, the muscles, the joints, the viscera. And their sole job is to selectively respond to noxious, potentially tissue-damaging stimuli.
So extreme heat or...
Yeah, extreme thermal heat, mechanical crushing force, or chemical irritants. If you touch a hot stove, the nociceptors fire. That process is nociception. But that firing signal traveling up your arm and into your spinal cord is not pain. not yet.
It's just data. Raw electrical and chemical data moving through a wire.
Exactly. Pain is what happens when that data reaches the brain and is processed, contextualized, and imbued with meaning. Pain is the subjective experience. And acutely, as we said, this is an absolute evolutionary necessity.
Because it teaches us.
Right. Acute pain has 3 specific dimensions that are highly adaptive. You have the sensory discriminative dimension that tells you where the stove is hot.
The coordinates.
Exactly. Then you have the affective motivational dimension. That makes the sensation feel deeply unpleasant so that you care enough to actually pull your hand away.
The drive to act.
Yes.
Yeah.
And finally, the cognitive evaluative dimension, which helps you learn and remember never to touch that stove again. It shapes your behavior to avoid environmental danger.
I mean, without it, we wouldn't survive childhood. You hear about those rare, tragic cases of congenital insensitivity to pain,
Oh, yes.
where children are born without functioning nociceptors,
Mm.
and they constantly suffer severe injuries, broken bones, burns, simply because their bodies cannot send that initial warning signal.
Yeah, those cases perfectly illustrate why we need the alarm system. It's essential. But the clinical problem we face in psychiatry and pain medicine is the inverse. If this is such a brilliantly designed evolutionary mechanism, we have to ask, at what point does this protective system turn against us?
Right. When does the alarm wire itself into the thermostat and freeze the house? What is the actual mechanism that turns a helpful warning into a chronic disease?
That is the process of chronification.
Chronification, yes.
Chronification is the transition from acute protective pain into a persistent maladaptive condition. When pain persists beyond the time of normal tissue healing, it entirely loses its protective role. You no longer need a warning about a broken bone that has already knitted back together, or, a surgical incision that healed 6 months ago.
But in chronification, the signals keep firing anyway.
Exactly.
And the brain doesn't just sit there passively receiving a persistent signal, does it? It adapts to it. It rewires itself.
It does, and this is where it becomes catastrophic for the patient. The neurobiology of the central nervous system physically changes through a process called neuroplasticity. The constant bombardment of noxious stimuli causes the networks in the brain and spinal cord to physically remodel themselves.
Wow.
The synapses, the connections between the neurons strengthen in a maladaptive way. They become sensitized. The threshold for what triggers an alarm drops significantly.
So a smaller trigger causes a bigger alarm.
Precisely. And the magnitude of the response to any given stimulus increases. The brain essentially amplifies the signal, leading to a profound increase in the aversive and motivational weight of the pain. The software becomes corrupted.
If the brain's hardware is literally rewiring itself to stay on high alert, what does that actually look like for the patient waking up in the morning? I mean, it cannot just be that their back hurts. The toll it takes on the psyche must be immense.
Oh, the clinical and public health reality is staggering. We see that in approximately 50% of cases where acute pain transitions into a persistent chronic condition, we witness the development of comorbid depression and anxiety.
50%? That's huge.
It is. And that's not a coincidence, nor is it simply a psychological reaction to being uncomfortable. As we'll explore, it's a shared neurobiological degradation, and crucially, these conditions exacerbate each other bidirectionally.
Meaning they feed off each other.
Exactly. The chronic pain worsens the depression, and the clinical depression literally worsens the neurological perception of the pain.
Which perfectly explains the failure of our historical approach to chronic pain. For decades, the medical model tried to treat chronic pain exactly like acute pain. We relied heavily on purely nociceptive blocking agents.
Most notably, opioids.
Right, opioids.
Yeah.
We tried to silence the peripheral hardware. Treating centralized pain with peripheral opioids is like trying to fix a software glitch that's causing error messages on your screen by taking a hammer and just smashing the computer monitor.
That is a brilliant analogy.
You stop seeing the output, but you have done absolutely nothing to address the corrupted code running in the processing center.
It hits the nail on the head. And the collateral damage from smashing that monitor is the escalating public health crisis we are currently living through.
The opioid crisis.
Yes. Because opioids lose their efficacy due to tolerance, patients require higher and higher doses to achieve the same numbing effect. This leads to severe withdrawal symptoms, profound physical dependence, and vast potential for misuse.
The numbers in the text are just bleak.
They are. The text notes massive increases in accidental opioid overdoses. In the U.S. alone, jumping from over 33,000 in 2015 to nearly 49,000 in 2018. It's an unimaginable strain on healthcare infrastructures globally.
It's a devastating reality check that proves we must understand the architecture of this system if we're ever going to actually help people suffering from it.
Absolutely.
So let's map that architecture. Let's trace the physical journey of this signal, starting with the peripheral hardware. If I say step on a nail, how does that physical tissue damage become an electrical signal heading for my spine?
Okay, so the journey begins with the nerve fibers themselves, which terminate as free, unencapsulated endings in your foot. And we need to distinguish between a few vital types of fibers here. First, we have the A delta fibers.
Hi, Delta.
Right, these are medium diameter, myelinated axons. Myelin acts like insulation on an electrical wire, allowing the signal to travel incredibly fast via saltatory conduction. It essentially skips down the nerve.
Okay, I picture the A delta fibers like immediate high-priority push notifications on your phone. They bypass everything else, they're rapid, and they deliver that sharp, highly localized first pain. You step on the nail, and that instantaneous sharp jolt that tells you exactly which millimeter of your heel was punctured, that's the A delta fiber screaming at you.
That is the perfect way to think of it, a push notification. But, as you know, immediately following that sharp jolt, you inevitably experience a duller throbbing ache.
Oh yeah, the one that sort of spreads out.
Yes, it makes the whole foot and ankle feel inflamed and awful. That secondary sensation is the work of the C fibers.
C fibers.
These are small diameter, unmyelinated fibers. Because they lack that myelin insulation, they conduct the signal much more slowly. They convey that poorly localized, aching second pain or burning pain.
The push notification versus the persistent, unread email banner that just sits there ruining your day.
Exactly. It's the deep, sick ache that makes you want to lie down.
Now, there are also A beta fibers, but they don't handle pain under normal circumstances, right?
Correct. A beta fibers are larger, rapidly conducting myelinated fibers that respond to innocuous mechanical stimulation.
Like a light touch.
Exactly. The brush of a feather or the sensation of your clothes resting against your skin. However, in certain pathological chronic pain states, the central nervous system becomes so sensitized and confused that the non-painful signals arriving from these A-beta touch fibers are misread by the spinal cord as pain.
Wait, really? The brain misinterprets the data entirely.
Yes. That is the phenomenon allodynia. A breeze glowing across the skin or the touch of a bed sheet is suddenly perceived as a searing blowtorch.
That sounds agonizing.
It is. It's a hallmark of neuropathic pain and a clear indicator that the central processing system has become profoundly corrupted.
Okay, so the nociceptors fire in the foot. The A delta and C fibers are carrying the signal up the leg. Where do they go?
The cell bodies for these primary sensory neurons are housed in the dorsal root ganglia, or DRG. These are nodules located just outside the spinal cord along the vertebral column.
And for the face, it's the trigeminal ganglion, right?
Spot on. From the DRG, axonal projections shoot the signal directly into the dorsal horn of the spinal cord. And they do this by releasing excitatory neurotransmitters into the synapse, primarily glutamate, as well as various neuropeptides like substance P. The dorsal horn is the first major relay station. Here, the first-order peripheral neurons synapse with the second-order neurons.
And this is where the anatomy beautifully reflects the psychology of pain. Because the signal splits, the axons of these second-order neurons cross over to the contralateral side, the opposite side of the spinal cord, and they form ascending pathways up to the brain. But they do not all take the same highway. There is a bifurcation of meaning right here in the spinal cord.
A bifurcation of meaning. I really like that phrasing. Because yes, the ascending pathways split into two main tracks. The first is the spinothalamic tract. This tract projects directly upward to the thalamic nuclei in the brain. This is your sensory discriminative pathway.
Its job is essentially logistical data processing.
Exactly. Where exactly on the body does it hurt, and how much physical intensity is there?
The pure data stream, the coordinates of the damage.
Right. But the second pathway is arguably more important for psychiatry. This is the spinoreticulothalamic tract.
That is a mouthful. Spinoreticulothalamic.
It is. This tract projects to structures in the brainstem, specifically the reticular formation, before heading to the thalamus. But crucially, it also sends branches to the parabrachial nucleus of the pons, which connects directly to the amygdala.
The amygdala, the fear center.
Exactly. This pathway does not care about precise location. It carries the emotional aversive payload. It carries the suffering, the fear, and the misery.
So before the signal even reaches your conscious cortex, before you have even had a chance to think about it, the spinal cord has already split the mail into two piles. Here are the coordinates of the damage, and here is a massive wave of primal fear.
That is the biological reality, and it's vital for understanding chronic pain patients. If you as a clinician only treat the spinothalamic data, if you only ask, rate your pain from 1 to 10, and focus on the physical intensity, you are completely ignoring the spinoreticulothalamic distress signals that are relentlessly flooding the patient's amygdala.
Wow. But the brain isn't just a passive receiver sitting at the end of these ascending highways, helplessly absorbing whatever pain signals come its way, is it? It's not just taking punishment. The brain fights back.
It definitely does.
It has its own descending modulation system. Let's talk about the gatekeepers. The periaqueductal gray, or the PEG, and the rostroventral medulla, the RVM.
This descending modulatory system is one of the most sophisticated feedback loops in neurobiology. As the spinoreticulothalamic tract ascends, it sends collaterals branching signals into the PEG in the midbrain. The PEG is essentially the master control valve for pain.
The master control valve.
Yes. When stimulated, the PEG projects down to the RVM in the brainstem. These two structures then send descending pathways back down the spinal cord to the dorsal horn.
So they're sending a signal back down to the exact place where the peripheral nerves are trying to hand off the pain data in the first place. They're acting like bouncers at the door of the spinal cord.
Precisely. They are regulating the gate. And the cellular mechanics of this volume dial in the RVM are fascinating. We categorize the neurons here into two main types, on cells and off cells.
Okay, let's start with the on cells.
The on cells are pro-nociceptive. When a painful stimulus occurs, these on cells activate. Their job is to facilitate the pain signal and trigger protective, nociceptive behaviors.
So if you touch that hot stove, the on cells fire rapidly to help trigger the withdrawal reflex that yanks your hand away.
Exactly. They turn the volume up to ensure immediate action.
But then you have the off cells. And from a clinical standpoint, these are the heroes of the story.
They really are. They are the body's internal endogenous analgesic system. When off cells activate, they send signals down to the dorsal horn to actively suppress and dampen the incoming pain signals. They turn the volume down.
And the clinical goldmine here is understanding what activates these off cells, right?
Yeah. Absolutely. They respond acutely to endogenous opioids, the painkillers our own bodies manufacture, like endorphins and enkephalins. They also respond to the neurotransmitters GABA and serotonin. Noradrenaline also plays a massive role here, acting on different adrenergic receptors to modulate both the on and off cells.
Here's where it gets really interesting. I want to pause here because this is the direct clinical link to psychopharmacology, isn't it?
It is.
When a psychiatrist prescribes a monoamine reuptake inhibitor like an SNRI or a tricyclic antidepressant for chronic neuropathic pain, this is exactly where those drugs are doing their heavy lifting.
Spot on.
We aren't just giving an antidepressant hoping to improve their mood so they care less about the pain. We are literally flooding the RVM and the spinal cord with serotonin and noradrenaline to empower those off cells to slam the gate shut on the incoming pain signals.
Yes, that is the exact mechanism. You are pharmacologically weaponizing the descending inhibitory pathways. You are helping the brain fortify its own defenses against the ascending noxious input. It is a physiological intervention, not just a psychological one.
Okay, so that is the modulation happening in the brainstem and spinal cord. But let's follow the signal all the way up to its final destination in the cortex. Where does the conscious, lived experience of pain actually coalesce? The concept of the pain matrix comes up often, usually divided into lateral and medial systems. How do they differ?
Well, the pain matrix isn't a single spot. It's a vast, distributed brain network. The lateral system receives input primarily from the thalamus and projects to the primary and secondary somatosensory cortices. This system maps the physical sensation spatially and temporally.
Okay.
So if a needle pricks your left index finger, a very specific tiny cluster of neurons in your right somatosensory cortex lights up. It gives you the high-resolution map of the event.
But the medial system is where the meaning is made.
It is. The medial system includes projections to the anterior cingulate cortex, or ACC, the insular cortex, and the prefrontal cortex. The system integrates the raw sensory data with emotional, cognitive, and motivational evaluations. This is where nociception officially becomes the complex, multifaceted experience of human suffering.
There's a point here that I think is the skeleton key for understanding the psychiatric component of pain. These medial integrative areas, the ACC, the insula, the prefrontal cortex, they overlap heavily with the exact same brain regions that process other non-painful stressors.
Yes, the sheer economy of the brain is remarkable. The brain doesn't have a completely separate, isolated circuit for physical pain and another dedicated circuit for emotional distress. It uses the exact same real estate.
That is wild.
The same neural networks that light up when you experience a severe physical burn also light up when you experience severe social rejection, profound grief, or chronic psychosocial stress.
So to the brain, suffering is suffering. The hardware doesn't differentiate between a broken heart and a broken arm.
At a foundational neurobiological level, there is profound overlap. And this explains why emotional distress and physical pain feel so viscerally similar, and why they amplify each other. When pain becomes chronic, this shared circuitry becomes chronically dysregulated. The persistent physical stressor of chronic pain fundamentally alters the reward and motivational mechanisms that live in these overlapping medial regions.
Okay, so if the brain's medial networks are shared between physical pain and emotional motivation, we have to look at the reward system. From an evolutionary standpoint, the cessation of pain, the relief, is a massive reward.
Oh, absolutely.
If you are freezing in a blizzard, a warm fire isn't just nice, it is the most rewarding thing in the world. If you are in agony, the stopping of the agony is the ultimate reward. How exactly does the brain calculate the value of this relief?
It calculates value using the basal ganglia and the associated limbic cortex. These regions integrate internal physiological signals with external environmental cues to encode the absolute value of the sensory signals we receive. Central to this is the saliency, reward, and motivation network, which heavily involves the ventral tegmental area, the VTA, and the nucleus accumbens.
So I always thought the nucleus accumbens was just the classic pleasure center. Dopamine goes up, we feel good, we eat a piece of cake, we experience joy. How on earth does that tie into the misery of chronic pain?
Right, the classic dopamine hit. But calling it the pleasure center is actually a common oversimplification. It's much better understood as a salience and motivation center. It assigns value to stimuli to drive behavior, and during acute pain, this network is highly active. Neuroimaging reveals a fascinating dichotomy within the nucleus accumbens itself, dividing it into the core and the shell.
How do the core and the shell react differently to pain?
In the nucleus accumbens core, dopamine release correlates with the negative affective responses, the subjective distress, and the motivation to escape the painful stimulus. It flags the pain as highly salient, highly aversive, and demands you do something about it. However, in the nucleus accumbens shell, the timing is completely different. Dopamine is released there after the pain stimulus terminates.
Wow, so the shell is literally encoding the sigh of relief.
Exactly. It reinforces the relief. It says to the brain, whatever behavior you just engaged in to make that pain stop, that was highly valuable. Remember that behavior. It proves that pain relief functions as a powerful form of positive reinforcement, essential for survival learning.
But this reveals the profound tragedy of chronic pain. In acute pain, the core screams danger, and the shell eventually rewards the relief. But in chronic pain, the relief never comes. The alarm just keeps ringing endlessly. What happens to the nucleus accumbens when the pain doesn't stop?
What's fascinating here is that the constant bombardment of negative salience becomes overwhelming. In chronic pain conditions like fibromyalgia or chronic neuropathic back pain, neuroimaging and animal models show that the dopamine receptors and dopaminergic neurotransmission in the nucleus accumbens actually downregulate. They deplete. The receptors physically retreat from the synapses.
Why would the brain do that? It seems completely counterproductive.
Initially, this downregulation is an adaptive, protective response. Imagine living next to a busy train track. At first, the noise is unbearable and you cannot sleep. Eventually, your brain tries to tune it out so you can function.
Right. Habituation.
Exactly. In chronic pain, the nucleus accumbens is trying to prevent the entire system from being short-circuited by endless distress signals. So it downregulates the dopamine receptors to mute the constant alarm. There is also evidence it does this to try and enhance the downstream functional capacity of the endogenous opioid systems.
But the cost of muting that alarm is unimaginably high. Because as we established, the nucleus accumbens isn't just an alarm bell for pain. It's the engine of motivation and reward for every aspect of human life.
This is where the initially adaptive response becomes profoundly maladaptive. By downregulating the dopaminergic function in the nucleus accumbens to mute the pain, the nervous system is simultaneously crippling the patient's capacity to experience normal reward or to engage in effortful motivation. In animal models, we see a drastically diminished capacity to perform effortful tasks to gain rewards, like, say, pressing a lever for food. The intrinsic drive is simply gone.
So by desperately trying to survive the chronic pain, the brain accidentally shuts off the biological capacity for joy.
That is the tragic biological reality. This dopaminergic downregulation in the nucleus accumbens is the precise intersection where chronic pain breeds the core, defining features of clinical depression and anhedonia.
Anhedonia being the inability to feel pleasure.
Yes. When a chronic pain patient presents in the clinic with profound apathy, lacking motivation to engage in physical therapy or socialize, they aren't just sad that they are hurting. Their neurological hardware for processing motivation and reward has been physically eroded by the persistent, noxious input.
That reframes the entire clinical picture. We often judge chronic pain patients as lacking willpower or being difficult, but their nucleus accumbens has literally downregulated its receptors just to survive the noise.
Exactly.
And this affective dysregulation isn't contained just to the basal ganglia, is it? Let's look at how other regions, the insula, the ACC, and the amygdala, all specialize in different flavors of suffering. If we start with the anterior cingulate cortex, the ACC, what is its specific role in this matrix?
The ACC, which receives heavy input via that spinothalamic pathway, is heavily implicated in encoding the sheer unpleasantness of pain. If the somatosensory cortex neutrally reports there is a dull ache in the lumbar spine, the ACC is the structure that translates that into, I cannot stand this ache for another second, it is ruining my life. Interestingly, in chronic pain states, CT scans have shown that the opioid receptors in the ACC, which normally help dampen this unpleasantness, are found to be downregulated.
The brain's natural ability to soothe the distress within the ACC becomes exhausted.
Precisely.
And what about the anterior insular cortex? It is frequently mentioned regarding interoception. How does interoception play into chronic pain?
So, interoception and your brain's continuous perception of the internal state of your body. The anterior insula is the monitor. It constantly evaluates your heart rate, your breathing, your gut motility, and your pain signals. In a healthy state, this happens quietly in the background. But in the context of chronic pain, a dysregulated anterior insula creates profound attentional biases towards physiological cues. It drives fear learning and massive anxiety responses based on bodily sensations.
I can vividly picture this in a clinical setting. Think of a patient who suffered a herniated disc 5 years ago. The structural injury might have fully healed, the MRI looks relatively clean, but their nervous system is completely sensitized. Now, they are absolutely terrified to bend over to tie their shoes. They are hyper-fixated on every single twinge, every minor muscle spasm in their lower back, interpreting perfectly innocuous signals as impending catastrophic damage.
Yes. If you are interviewing that patient, you are literally watching their anterior insula and amygdala operating in massive overdrive. The amygdala, bereft of its normal endogenous opioid neurotransmission due to the chronic state, is driving intense negative affect, fear, and avoidance behaviors. The insula is hyper-focusing their conscious attention directly onto the lower back, artificially amplifying the signals. They are trapped in an allostatic state of constant threat assessment.
This brings us to a critical pivot regarding integration and clinical reasoning. If the brain's medial networks can amplify pain through fear, hyperfixation, and catastrophizing, then logic dictates that we should be able to use the brain to do the exact opposite.
Right.
We should be able to modulate the pain from the top down. Can we literally think our way to less pain?
We absolutely can, and the mechanisms behind it are robust. The perception of pain is exquisitely sensitive to cognitive modulation. It is not a bottom-up absolute where you simply feel whatever the nerve dictates. Cognitive processes actively change the biological processing of the pain. Catastrophizing, having heightened attention, rumination, and expectations of threat regarding the pain, induces higher pain sensitivity. It physically amplifies the signal.
That makes it worse.
Yes, but distraction from pain, or cognitively reframing its meaning, is associated with actual measurable reductions in pain-associated blood flow in the somatosensory cortex, the thalamus, the insula, and the ACC.
Wait, brain scans show the pain matrix calming down simply because the patient changed their cognitive appraisal of the stimulus?
Exactly.
But how does a thought, an abstract cognitive process, physically alter a spinal signal?
It happens via the executive regions of the brain, specifically the prefrontal cortex, the dorsolateral prefrontal cortex, or DLPFC, and the ventrolateral prefrontal cortex. These are your higher-order reasoning and executive control centers. When you reframe pain, perhaps through cognitive behavioral therapy or engage in intense focused distraction, these prefrontal regions activate. They project down to the anterior, cingulate, and insular circuitry, which in turn project directly down to the periaqueductal gray, the pay in the midbrain.
The master control valve we talked about earlier, the bouncer at the door.
Yes, the executive cortex essentially issues a top-down veto. The DLPFC tells the PEG, we are focusing on something else right now. We have assessed the sensation and it's not a threat. Turn the volume down. The PEG then signals the RVM to activate those off cells, inhibiting the nociceptive transmission right at the level of the dorsal horn in the spinal cord. It is top-down cognitive control asserting dominance over lower-level sensory input.
I have to push back on a historical concept here, or rather ask you to completely reframe it based on this mechanism. For my entire medical education, the placebo effect was treated like a nuisance. It was the confounder in clinical trials that we had to control for.
Oh, absolutely.
It was viewed as fake relief because the patient thought they got the real drug but only got a sugar pill. So it was just a psychological trick. But the neurobiology we're discussing shatters that view. Can you explain the placebo effect not as a trick, but as a robust biological event?
Redefining the placebo effect is one of the most important things a clinician can do. Placebo analgesia is not fake pain relief. The patient isn't lying, they aren't just thinking positive, and they aren't gullible. Placebo is a tangible, measurable neurobiological cascade. It is the brain successfully deploying its own descending modulatory pharmacy.
How does that cascade actually initiate and execute?
It begins with expectation and context. When a patient is in a therapeutic environment, interacting with a trusted clinician, and is given a treatment they expect to work, even if the pill itself is biologically inert, the dorsolateral prefrontal cortex processes those environmental cues. The white coat, the stethoscope, the assurance in the doctor's voice.
The rituals of medicine.
Exactly. The DLPFC generates a positive expectation of relief. This expectation engages the nucleus accumbens,
The salience and reward center. It recognizes the impending relief as highly valuable.
Yes. The nucleus accumbens uses dopamine to signal this salience, which then activates the descending pain regulatory networks. The signal hits the amygdala, the ACC, and crucially, the PEG. The PEG is then stimulated to release massive amounts of endogenous opioids, as well as endocannabinoids, down into the spinal cord. The expectation of the drug literally causes the brain to manufacture and release its own internal version of the drug. Placebo is top-down endogenous analgesia.
That is staggering. The ritual of care is the actual trigger that unlocks the brain's opioid reserves. And presumably, the nocebo effect, where a patient expects a treatment to hurt or cause side effects and then actually experiences them, is this exact same system. But the expectations are driving pro-nociceptive anxiety, activating the on cells and turning the volume up.
That is entirely correct.
Yeah.
Cholecystokinin, or CCK, has been implicated in facilitating this hyperalgesic nocebo response. It highlights the immense biological power of the therapeutic alliance and clinical communication. The words you use as a doctor have biological consequences.
So what does this all mean? This brings us to the application of all this knowledge. We understand the anatomy, the ascending and descending tracts, the chronification, the tragic overlap with depression in the nucleus accumbens, and the power of top-down modulation. How do we use psychopharmacology to actually treat patients who are suffering from these complex, intertwined conditions? We need to move beyond simply throwing opioids at the peripheral nociceptors and instead target the central mechanisms. Let's deep dive into the specific classes, starting with SNRIs, serotonin, and noradrenaline reuptake inhibitors like duloxetine or venlafaxine. We touched on them briefly, but what is the cellular journey here?
SNRIs are incredibly valuable, particularly for neuropathic pain conditions like diabetic neuropathy or fibromyalgia. Their mechanism is elegant. By blocking the reuptake transporters for serotonin and noradrenaline, they prevent these neurotransmitters from being swept away after they are released into the synaptic cleft. This increases the concentration and availability of these monoamines in the descending pathways of the brainstem and spinal cord.
And because we have more serotonin and noradrenaline floating around the RVM and the dorsal horn, we're giving the descending inhibitory system more fuel.
Yes. You are heavily activating the off cells, enhancing their ability to dampen nociceptive transmission at the spinal level. And simultaneously, because these drugs operate systemically, they are also treating the comorbid depression by regulating affective circuits in the limbic system and prefrontal cortex. You are treating the emotional pain and the physical pain through shared monoamine pathways.
And what about the older class, the tricyclic antidepressants, or TCAs, like amitriptyline? Historically, these were the gold standard for neuropathic pain. They also boost serotonin and noradrenaline, right? But we tend to use them less frequently now as first-line agents, or at least with much more caution. Why the shift?
TCAs share that core mechanism of monoamine reuptake inhibition, and they are indeed highly effective for neuropathic pain, sometimes even more so than SNRIs in certain patients. However, TCAs have a much messier receptor binding profile.
Messier in what way?
Well, in addition to targeting serotonin and noradrenaline transporters, they act as potent antagonists at muscarinic acetylcholine receptors, histamine H1 receptors, and alpha-1 adrenergic receptors.
That explains the classic TCA side effect profile. By blocking muscarinic receptors, you get anticholinergic effects of the severe dry mouth, constipation, blurry vision, and urinary retention.
Right.
By blocking histamine, you get profound sedation and weight gain. And blocking alpha-1 adrenergic receptors leads to orthostatic hypotension patients standing up and feeling dizzy or fainting.
Exactly. The side effect burden is much broader because the drug is hitting so many unintended physiological targets. SNRIs are favored because they are more selective, providing the descending inhibition without the anticholinergic and antihistaminergic baggage.
Let's shift to the gabapentinoids, gabapentin and pregabalin. We see these prescribed constantly for nerve pain, postherpetic neuralgia, sciatica. How do they fit into this matrix? Because they aren't working on monoamines like serotonin.
Gabapentinoids operate on an entirely different mechanism. Despite the name, they do not bind to GABA receptors. Instead, they bind with high affinity to the alpha-2 delta subunit of voltage-gated calcium channels in the central nervous system.
Okay, let's unpack the cellular mechanics of that. What does blocking a voltage-gated calcium channel actually achieve in the context of a hyperactive chronified pain network?
Think about how a neuron fires. In order for a presynaptic neuron to release its excitatory neurotransmitters, like glutamate or substance P, into the synapse to propagate the pain signal to the next neuron, an action potential arrives at the terminal. This change in voltage causes calcium channels to open. Calcium floods into the cell. This influx of calcium is the biological trigger that causes the vesicles containing neurotransmitters to fuse with the membrane and spill their contents into the cleft.
So calcium is the trigger pulling the gun.
Yes. By binding to that alpha-2 delta subunit, gabapentinoids inhibit that vital influx of calcium. If the calcium cannot enter, the vesicles cannot fuse. This effectively throttles the release of excitatory neurotransmitters. It calms the hyperexcitable sensitized nervous system down. It's like putting a governor on the engine of the spinal cord so it cannot rev too high.
That makes perfect sense.
And because this central excitability is also a feature of anxiety disorders, it explains why gabapentinoids possess strong anxiolytic properties as well.
That is fascinating. The text also mentions anticonvulsants like carbamazepine and oxcarbazepine.
These act primarily as use-dependent, voltage-sensitive sodium channel blockers. While calcium handles neurotransmitter release, sodium channels are responsible for the propagation of the electrical action potential itself down the axon. By blocking sodium channels, particularly those that are firing rapidly and repetitively, they inhibit the electrical storm and similarly inhibit the downstream release of glutamate.
Oh, right.
They're particularly famous and effective for treating trigeminal neuralgia, a specific type of excruciating electric shock-like facial pain. But importantly, carbamazepine is also utilized in managing bipolar disorder and acute treatment-refractory depression, once again highlighting the profound overlap in these therapeutic neurobiological mechanisms.
And finally, we have to talk about ketamine, which has had an absolute renaissance in psychiatry recently, moving from an anesthetic to a rapid-acting antidepressant. How does it modulate pain?
Ketamine is an NMDA receptor antagonist. The NMDA receptor is a major docking site for glutamate, the primary excitatory neurotransmitter in the central nervous system. During the chronification of pain, under the constant barrage of nociceptive input, NMDA receptors become hyperactive. They lose their normal magnesium block, leading to a massive influx of calcium and a phenomenon called wind-up or central sensitization in the spinal cord. The system becomes hyperreactive.
And ketamine steps in to block that hyperreactivity.
Ketamine physically blocks the pore of the NMDA receptor, interrupting that central sensitization. It resets the system. And beautifully, meta-analyses and clinical trials demonstrate its profound efficacy, not just in modifying persistent opioid refractory pain, but in treating severe treatment-refractory depression and suicidal ideation through parallel mechanisms of promoting rapid neuroplasticity and synaptogenesis in the prefrontal cortex.
It is incredible how all roads lead back to this shared circuitry, which really brings us to the ultimate synthesis of this entire discussion, what we might call the fallacy of siloed care.
This is perhaps the most important takeaway for modern medical practice, particularly for trainees. Given the complex, interwoven relationships among pain, mental health, substance use disorders, and even social and economic disparities, the historical fragmentation of healthcare into distinct disease-based silos is fundamentally flawed and highly unproductive.
The idea that you send the patient to the pain clinic for their lower back, the psychiatrist for their major depression, and the addiction specialist for their iatrogenic opioid dependence, and none of those specialists ever speak to each other or coordinate a unified treatment plan.
It ignores the neurobiological reality that these are all manifestations of the same overloaded system. Persistent pain is an allostatic process. It places an immense chronic wear and tear on the body and brain. It promotes negative affective responses, physically degrades the reward systems in the nucleus accumbens, exhausts the descending inhibitory pathways, and heavily enhances the individual's propensity to develop major depressive and anxiety disorders.
It's all connected.
Treating these conditions in isolation is like trying to fix a sinking ship by only patching the holes in the dining room while completely ignoring the massive breach in the engine room. Modern psychiatry requires integrated care that addresses the entire allostatic load.
That is a brilliant synthesis. We have covered a massive amount of ground today, completely reframing how we view suffering. We started by redefining pain not just as a physical input, but as a multidimensional construct comprising sensory, emotional, and motivational elements. We saw how the spinothalamic tract handles the logistical where and how much, while the spinoreticulothalamic tract and medial structures, the insula, the ACC, the amygdala, transform that raw nociception into the subjective experience of misery.
We highlighted how the brain is an active participant. Context, expectation, and top-down cognitive processing from the prefrontal cortex literally alter spinal signals through the periaqueductal gray and the rostroventral medulla. We discussed the tragedy of chronification, where persistent pain physically changes central processing, down-regulating dopamine receptors in the nucleus accumbens, and linking chronic pain inextricably with the neurobiology of clinical depression and anhedonia.
And finally, we saw that effective modern treatment must target these shared neurobiological pathways. Whether we are using SNRIs to boost ascending inhibition, gabapentinoids to throttle calcium influx and calm central excitability, or cognitive reframing to activate endogenous opioids via the placebo pathway, we are intervening far beyond mere peripheral input.
I want to leave you with a final thought to ponder, one that builds on our discussion of the placebo effect and the power of top-down modulation. We established that expectation and context that the therapeutic alliance can physically activate the brain's endogenous opioid system via the prefrontal cortex to relieve pain. If that is biologically true, then how might the very physical design of our hospitals and clinics, the harsh fluorescent lighting, the chaotic noise levels, the sterile aesthetic environment, and the specific, subtle words we use during a hurried clinical encounter be just as biologically active, for better or worse, as the medications we prescribe? If the brain builds the experience of pain from context, are we actively designing clinical contexts that heal or contexts that harm?
That is a staggering thought. The architecture of the clinic itself as a biological intervention. I love that. All right, before we wrap up completely, let's do a quick mental check for you to reinforce these concepts. We're going to pose a few clinical scenarios based on the deep dive today. I'll throw out the question, give you a second to think, and then we will break down the rationale, directing you back to the core concepts of the chapter. Ready?
Let's do it.
Okay, first scenario. Think back to our peripheral nerves. If a patient touches a hot stove and gets that instantaneous sharp shock that makes them yank their hand away before they even consciously process the heat, which nerve fibers are screaming.
That initial sharp, well-localized sensation is carried by the A-delta fibers. Remember, they are myelinated, allowing for rapid saltatory conduction. It is the push notification. The dull, burning ache that follows a few seconds later is mediated by the slower, unmyelinated C fibers.
Excellent. Second scenario, focusing on mechanism. We talked about the gatekeepers in the brainstem, specifically the rostroventral medulla, the RVM. Which type of cells in the RVM are acting as the body's internal brake system, responding to serotonin and endogenous opioids to block pain signals at the spinal cord?
Those are the off cells, while on cells are pro-nociceptive and facilitate pain to trigger withdrawal reflexes. The off cells project down to the dorsal horn to actively inhibit incoming nociceptive transmission. Activating these cells is a primary goal of monoamine-based psychopharmacology.
Spot on. Third question, tying into clinical psychiatry. You have a patient with chronic fibromyalgia who exhibits profound anhedonia. They've completely lost the drive to engage in hobbies they used to love. According to the neurobiology we discussed, this lack of motivation is most closely associated with the downregulation of which neurotransmitter system and in what specific brain region.
This is the dopaminergic system, specifically within the nucleus accumbens. The constant barrage of negative salience from chronic pain leads to a maladaptive downregulation of dopamine receptors here. This mutes the pain salience slightly, but tragically cripples the patient's capacity for reward and motivation, biologically linking their chronic pain to clinical depression.
Question 4. Looking at the medial pain matrix. Which specific cortical region is most heavily implicated in encoding the unpleasantness of pain, the feeling of, I cannot stand this, rather than just mapping where it hurts?
That would be the anterior cingulate cortex, or ACC. While the somatosensory cortex handles the sensory mapping, medial structures like the ACC receive input and translate that data into the subjective emotional experience of distress.
Question 5. Applied pharmacology. We know SNRIs help with neuropathic pain, but what is the actual primary mechanism by which a drug like duloxetine provides this physical relief?
By blocking reuptake, SNRIs increase the availability of serotonin and noradrenaline in the synaptic clefts of the descending pathways. This abundance of monoamines heavily potentiates the descending inhibitory pain pathways, giving the off cells in the RVM the fuel they need to dampen nociceptive transmission at the spinal level.
And final question, returning to our mechanistic reframing of placebo, we established it as a top-down neurobiological network. Which cortical region is primarily responsible for processing the environmental cues, the doctor's white coat, the therapeutic setting, and generating the positive expectations that initiate this endogenous opioid cascade?
That is driven by the dorsolateral prefrontal cortex, or DLPFC. The DLPFC integrates the therapeutic context, generates the expectation, and projects down to the nucleus accumbens and eventually the periaqueductal gray to release endogenous opioids. It proves that placebo is a top-down executive function, fundamentally reliant on the prefrontal cortex.
Outstanding. Well, we started this deep dive by picturing the body as a house with an acute pain security system that functions perfectly until chronification wires the siren directly into the thermostat, fundamentally changing the environment we live in. We have seen the rigorous biological truth of that metaphor today. Pain is not just a broken window, it is the entire atmosphere of the house, constructed by a brilliant but vulnerable brain. Thank you for joining us as we explored the intricate wiring. Here are the details of this episode.
Pain systems. Interface with affective and motivational mechanisms. Byline. More than sensation, how pain becomes meaning, emotion, and action.